Okay, I am back. Let us continue. Raise your hand if you're able to hear me clearly. All right. So continuing with geriatric emergencies, we were on to syncope. Syncope is a very important finding in a geriatric population. It can be an indication of something life-threatening, and always assume that it is something life-threatening until proven otherwise. It is often caused by an interruption of blood flow to the brain. Neuropathy. This is a disorder of the nerves of the peripheral nervous system. Function and structure of the peripheral motor, sensory, and autonomic neurons are impaired. Symptoms depend on which nerves are affected and where these nerves are located within the body. Motor nerves will, if the motor nerves are affected, this will result in weakness, cramps, spasms. They'll have issues with their balance and coordination. If it's the sensory, they'll have tingling sensation, they'll complain of numbness, itching, pain, burning, freezing, or extreme sensitivity to touch. And if it's the autonomic, then their blood pressure and heart rate can be affected. They can have issues with constipation and bladder and sexual dysfunction. Let's look at changes in the gastrointestinal system. There is a reduction in the volume of saliva. There is dental loss. There's gastric secretions are reduced. Changes in gastric motility occur. There's incidence of certain diseases involving bowel increases. Blood flow to the liver declines. There's issue. Backtrack. Age-related changes in the GI system. That's where I'm at. There are issues with the dental problems. There is decrease in saliva and sense of taste. There's poor muscle tone of the sphincter between the esophagus and the stomach, so food doesn't move down very well into the intestines. There is decrease in hydrochloric acid, so the food doesn't break down very well, and that can affect how nutrients are absorbed. There's weakening of the rectal sphincter. GI bleeding can be caused by inflammation, infection, or obstruction of the upper or lower GI tract, usually heralded by hematemesis. Bleeding that travels through the lower digestive tract usually manifests as melena, so it's going to be dark in color if it's digested. Red blood usually means a local source of bleeding, such as hemorrhoids. A patient with GI bleeding may experience weakness, dizziness, or syncope. Specific GI problems in older patients include diverticulitis, bleeding in the upper and lower GI system, peptic ulcers, gallbladder disease, bowel obstruction. When assessing patients, ask about NSAID and alcohol use. Orthostatic vital signs can help to determine if a patient is hypovolemic. Blood pressure and pulse rates are obtained with the patient lying, sitting, and standing. Note any drop in the blood pressure and any increase in the heart rate that occurs as the patient moves to an upright position. Acute abdominal non-gastrointestinal complaints. Extremely difficult to assess in the pre-hospital setting. The most serious threat from abdominal complaints is blood loss, and the most common culprit is going to be the AAA, abdominal aortic aneurysm. It can be fatal. The walls of the aorta weaken and blood leaks into the layers of the vessel. If enough blood is lost, shock will occur. Changes in the renal system. Age brings changes in the kidneys. There is reduced renal function, there is a reduction in renal blood flow, and there is tubule degeneration. Changes in the genitourinary system include a decreased bladder capacity, declined sphincter muscle control, decline in voiding senses, increase in nocturnal voiding, benign prostatic hypertrophy, which is enlargement of the prostate, common in the male population that's over 60. So it's common in your geriatric male patients. Incontinence is not a normal part of aging, and it can lead to skin irritation, skin breakdown, and urinary tract infection. Stress incontinence occurs during activities such as coughing, laughing, sneezing, lifting, and exercise. Urge incontinence is triggered by hot or cold fluids, running water, or thinking about going to the bathroom. The opposite of incontinence is urinary retention or difficulty urinating, which is very common with patients who have an enlarged prostate. In men, enlargement of the prostate can place pressure on the urethra, making it difficult for them to pass their urine, and it can cause severe pain. Bladder and urinary tract infections can cause inflammation. In severe cases of urinary retention, patients can go into renal failure. Changes in the endocrine system. There's reduction in thyroid hormones, thyroxine. Signs and symptoms will include slower heart rate, fatigue, drier skin and hair, cold intolerance, weight gain. Other endocrine changes include an increase in the secretion of antidiuretic hormone, and this can cause electrolyte imbalance or fluid imbalance within the body. Hyperglycemia is very common, so especially the type 2 issue where they become severely dehydrated, hyperosmolar hypoglycemic non-ketotic syndrome or coma. That's very common in the geriatric population. There is increases in the levels of norepinephrine, possibly having a harmful effect on the cardiovascular system. So if there's too much epinephrine being produced, then the blood vessels will be overstimulated, and they can go into vasoconstriction that can be harmful for the body. Hyperosmolar hypoglycemic non-ketotic syndrome or coma is a type 2 diabetic complication in older people. On assessment, you may see warm, flushed skin. They're gonna have signs of dehydration. They're gonna be pale, dry. They're gonna have pale, dry skin. The oral mucosa is gonna be pale and dry. The tongue is gonna shrink, and they'll show signs of shock. Assessment of the patient should include obtaining blood pressure, distal pulses, listen to lung sounds, temperature, assessment of blood glucose level if permitted by local protocol, and every ambulance unit should have a GMR machine on board. Changes in the immune system. Infections are commonly seen in older people because of their increased risk. They are less able to fight infections. Anorexia and fatigue, weight loss, falls, or changes in mental status may be primary symptoms. Pneumonia and UTIs are common in patients who are bedridden. Signs and symptoms may be decreased because of loss of sensation, lack of awareness, or the fear of being hospitalized. Changes in the musculoskeletal system. Decrease in bone mass, especially in postmenopausal women. Bones become more brittle and tend to break more easily, and that's why hip fractures is common in that group. Joints lose their flexibility, and a decrease in the amount of muscle mass often result in less strength, so they are prone to falls, and if they fall, bones will fracture easily, and if they hit the head, blood vessels will tear easily and bleeding can occur in the skull. Changes in physical abilities can affect older adults' confidence in mobility. Muscle fibers become smaller and fewer. Motor neurons decrease in number. Strength declines. Ligaments and cartilage of the joints lose their elasticity. Cartilage goes through degenerative changing or changes. Osteoporosis is characterized by a decrease in bone mass, so reduction in bone strength and greater susceptibility to fracture. So as the bone mass decreases, the bone becomes more vulnerable to breaking or fractures. The extent of bone loss depends on genetics, body weight, smoking, alcohol consumption, level of activity, diet. Osteoarthritis is a progressive disease of the joints that destroys cartilage, promotes the formation of bone spurs, and leads to joint stiffness. It results from wear and tear, and it affects joints in the hands, the knees, the hips, and the spine. Changes in the skin. Proteins that make the skin pliable decline with age. Layer of fat under the skin becomes thinner. Bruising becomes more common. Sweat glands do not respond as readily to heat. Pressure ulcers is very common, and the depth of the pressure ulcers is similar to the depth of burns. So it can affect the top layer, middle layer, and bottom layer of the skin. Sometimes referred to as bed sores or the cubitus ulcers. The pressure from the weight of the body cuts off the blood flow to the area of the skin. With no blood flow, a sore develops, and there are different stages of ulcer development. So you have stage 1, which is non-blanching redness with damage under the skin. Stage 2, blister or ulcer that can affect the dermis and epidermis. Stage 3, invasion of fat layer through to the fascia. Stage 4, invasion to muscle or bone. Toxicology. Older people are more susceptible to toxicity because of decreased kidney function, altered gastrointestinal absorption, and decreased liver function. Kidneys undergo many changes with age. Decreased liver function makes it harder for liver to detoxify the blood and eliminate medications and alcohol. Typical OTC medications can have negative effects when mixed with other or with herbal substances. alcohol, and prescription medications. Polypharmacy refers to the use of multiple prescription medication by one patient, common in a geriatric population. Negative effects can include overdosing, negative medication interaction, medication non-compliance occurred due to financial challenges, inability to open containers, impaired cognitive vision, and hearing ability. Depression. Depression is not a part of normal aging, but a medical disease. Treatable with medication and therapy. If depression goes unrecognized or untreated, it is associated with a higher suicide rate in the geriatric population. So they tend to commit suicide very well, or they are very thorough with their methods. Risk factors include history of depression, chronic disease, and loss. The following conditions contribute to the onset of significant depression. So substance abuse, isolation, prescription medication use, chronic medical conditions. Suicide. Older men have the highest suicide rate of any age group in the United States. Older persons choose much more lethal means than younger victims, generally have diminished recuperative capacity to survive an attempt. So if it's an attempted suicide, because of the degeneration of the body systems, they do not recover very well. Common predisposing events and conditions include the death of a loved one, physical illness, depression and hopelessness, alcohol abuse, alcohol dependence, loss of meaningful life roles. When assessing the patient who is displaying signs of depression, it is appropriate to ask if he or she is considering suicide. The answer is yes. Then the next question should be, do you have a plan? Include this information in your report. Now, with the pediatric chapter, we became familiar with the pediatric assessment triangle. With geriatrics, we use the GEMS diamond to remember important things about the geriatric population. So it was created to help you remember what is different about older patients, not intended to be a format for the approach to geriatric patient or replace the ABCs of care. It serves as an acronym for the issues to be considered when assessing every older patient. So it starts off with G. The G is a reminder about geriatric patients. Older patients will present atypically, very important. So they do not present with the typical signs and symptoms of the common emergencies. Be familiar with the normal changes of aging and how they will affect the presentation of specific emergencies. Environmental assessment. So that's what the E represents. The environment can help give clues to the patient's condition and the cause of the emergency. So pay close attention to the environment that you find the patient in. The M represents medication. So medical assessment, M represents medical assessment. Medical assessment, older patients tend to have a variety of medical problems and numerous medications. And we need to spend time to collect the relevant history and document these medications. going to be important to the physicians who are receiving the patient if they need to administer medication, because they may be taking something that can interact with a medication that is required. So spend time, get that history. Don't write a bag of medication on your report. Write out the medications. The S is for social assessment. Older people may have less of a social network. They may need assistance with activities of daily living. Consider obtaining information pamphlets about some of the agencies for older people in your area, right? And the common practice is to just put these people in nursing homes. It's not a good thing, right? As I stated previously, I've seen some horrible patient presentations in nursing homes. Special considerations in assessing a geriatric medical patient. Assessing an older person can be challenging because of communication problem, their ability to hear or see, changes in their level of consciousness, complicated medical history, and effects of medication. Start with your scene size up. Geriatric patients are commonly found in their own homes, retirement homes, or skilled nursing facilities. Many older people live alone. Access may be hampered if their condition prevents them from getting to the door. Take note of negative or unsafe conditions. Mechanism of injury or nature of illness may be difficult to determine in older people with altered mental status or dementia. Ask the family member, caregiver, or bystander why he or she called. Multiple and chronic disease processes may also complicate the determination of the NOI. So you have to be a detective, cipher through the information that you're given, look at the patient presentation, and then figure out what is most significant at this point in time. Chest pain, shortness of breath, and altered level of consciousness should always be considered serious. Mr. Jones, you have a question?
No, sir, it's an accident. Sorry about that.
After the primary assessment, after the scene size up, next is your primary assessment. Address life threats, determine transport priority, form a general impression. You should be able to tell if the patient is generally in stable or unstable condition. Use the AVPU scale to determine the patient's level of consciousness. Assess airway and breathing. Anatomic changes that occur as a person ages predispose geriatric patients to airway problems. Ensure that the patient's airway is open, not obstructed by dentures, vomitus, fluid, or blood. Anatomic changes can also affect the patient's ability to ventilate or breathe effectively. Loss of mechanisms that protect the airway cause a decreased ability to clear secretions. Airway and breathing issues should be treated with oxygen as soon as possible. For circulation, poor perfusion is a serious issue in older adult patients. Physiologic changes may negatively affect circulation. Vascular changes and circulatory compromise might make it difficult for you to palpate or feel a pulse. Transport decision. Any complaints that compromise the ABCs should result in prompt transport. Determine conditions that are life-threatening. Treat them to the best of your ability. Provide transport to priority patients. Priority patients are those who have poor general impression, issues with airway and breathing, changes in their level of consciousness, hypoperfusion, severe pain, bleeding that cannot be controlled. Older people will easily decompensate. After your primary assessment, next phase is your history taking. Investigate the chief complaint, find and account for all medications. Write down the name of the medications. Obtain a thorough patient history. Determine early whether the altered level of consciousness is acute or chronic. Multiple disease processes and multiple and or vague complaints can make your assessment complicated. Collect a sample history. You may have to rely on a relative or caregiver to assist you. List the patient's medications or take the medications with you to the hospital. The last meal is particularly important in patients with diabetes. Transport to a facility that knows the patient's medical history if possible. After the history taking phase, next is your secondary assessment. May be performed unseen en route to an emergency department, or you might not have any time at all to perform a secondary assessment. Physical examination. An older patient may not be comfortable with being exposed. Protect his or her modesty. Consider the need to keep your patient warm during exam, especially if you suspect shock. We do not want a patient in shock to get cold. Vital signs. The heart rate should be in normal adult range but may be compromised by medications such as beta blockers, which block beta receptors. Weaker and irregular pulses are common. Circulatory compromise may make it difficult to feel a radial pulse. Consider other pulse points. Blood pressure tends to be higher. So as we age, our blood pressure tends to go up. Capillary refill is not a good assessment, so don't rely heavily on that for your geriatric population. The respiratory rate should be in the same range as a younger adult. Be sure to auscultate breath sounds. That's extremely important for your geriatric population. Carefully assess pulse oximetry data. However, whatever information you get on your pulse oximeter, look at your patient presentation and see if it matches the reading on your pulse oximeter. So what is the patient telling you? You treat the patient presentation, you will not treat your devices. After the secondary assessment, the final phase is your reassessment. Reassess the geriatric patient often, reassess vital signs, reassess the patient's complaint, recheck interventions, identify and treat changes in the patient's condition. And your interventions will include maintain position of comfort, provide assisted ventilations if necessary, administer glucose for a patient with diabetes if they present with signs and symptoms of hypoglycemia. In specific cases, you may also assist with nitroglycerin and aspirin, and that will be for your patient with a suspected MI, or inhalers or nebulization for your patient with lower airway obstruction, characterized by wheezing. Provide psychological support. Communication and documentation. Communicate your findings and interventions you use to emergency personnel. Document all history, medication, assessment, and intervention information. Right? This is Table 3.5-4, Geriatric Patient Assessment Guidelines. Very important table. Ensure that you review it. Trauma and geriatric patients. Conditions that create risk and complicate assessment. Slow homeostatic compensatory mechanism. So their body is slow in how it compensates to maintain balance. They have limited physiologic reserves. The normal effects of aging on the body can affect how they deal with trauma. Existing medical issues. Physical findings in an older adult may be more subtle and more easily missed. Mechanisms are much more minimal. Recuperation from trauma is longer and often less successful. Many injuries are under-triaged and undertreated. Because of changes in the body, older pedestrians are more likely to have life-threatening complications after being struck by a vehicle. They commonly suffer injury to the legs and arms. Other injuries can be caused by secondary collision onto the street, often involving the head. Older people are more likely to experience burns because of altered mental status, inattention, and a compromised neurologic status. The risk of mortality is increased when pre-existing medical conditions exist, when they have a weak immune system, when fluid replacement is complicated by issues with their kidneys. Higher mortality rate from penetrating trauma in older adults, especially gunshot wounds. Penetrating trauma can easily cause serious internal bleeding. Falls are the leading cause of fatal and non-fatal injuries in the older patients. Very important slide. Nearly half of fatal falls in geriatric patients is going to lead to traumatic brain injury. And we know why that is occurring, because the brain shrinks with age and there is more space inside the skull for the brain to shift around. Anatomic changes and trauma. Changes in pulmonary, cardiovascular, neurologic, and musculoskeletal systems make older patients more susceptible to trauma. A geriatric patient's overall physical condition may lessen the body's ability to compensate for simple injuries. As a result of osteoporosis, older patients are prone to fractures, especially of the hip. So hip fractures is very common in the geriatric population. Contributing factors: stresses of ordinary activity, a standing fall, vitamin D and calcium deficiencies, metabolic bone disease, tumors. Geriatric patients with osteoporosis are also at risk for pelvic fractures. Takes more force to fracture the pelvis though. With age, the spine stiffens, and as a result of shrinkage of disc spaces and vertebrae become brittle. Compression fractures of the spine can occur as a result of that. Because the brain tissue shrinks with age, older patients are more likely to sustain closed head injuries. Acute subdural hematomas are among the deadliest of all head injuries. Serious head injuries are often missed because the mechanism may seem relatively minor. Other factors that predispose an older patient to a serious head injury include long-term alcohol abuse, recurrent falls and repeated head injury, anticoagulant medication. Environmental injury. Internal temperature regulation is slowed Half of all deaths from hypothermia occur in older people, including most indoor hypothermia deaths. Death rates for hyperthermia are more than doubled in older people. People older than 85 years are at the highest risk. Special considerations in assessing geriatric trauma patients. Trauma is never isolated to a single issue when you are assessing and caring for geriatric patients. Very important point. Scene size up. Look for clues that indicate your patient's traumatic incident may have been preceded by a medical incident. So was this trauma caused by a medical problem? Bystander information may be helpful. MOI is important in establishing whether an injury is considered critical and if it affects treatment and transport consideration. After your scene size up, primary assessment. Address live threats. Determine transport priority. Recommended that older trauma patients be transported to a trauma center. Form a general impression. Is the patient condition stable or unstable? Use your AVPU and your Glasgow Coma scale to determine mental status. Assess airway and breathing. If the patient is talking to you, is the airway clear? Patients who have noisy respirations have airway compromise. Older patients may have a diminished ability to cough, so suctioning is important. Assess for the presence of dentures. Circulation. Manage any external bleeding immediately. Drinking alcohol and taking anticoagulant medication is a bad combination. So drinking alcohol and taking anticoagulant medications can make internal bleeding worse or external bleeding more difficult to control. Older patients can more easily go into shock. Patients who were hypertensive prior to injury may have a normal BP when they are actually in shock. After the primary assessment, history taking. Investigate the chief complaint. Considerations in your assessment must include past medical conditions, even if they are not currently acute or symptomatic. After the history-taking phase, secondary assessment. Physical examination, performed in the same manner as for any adult, but with considerations of the higher likelihood of damage for trauma. Any head injury can be life-threatening. Pay attention to your lung sounds. Look for bruising and other evidence of trauma. Pay attention to your geriatric patients' lung sounds. Very important. Vital signs. Assess the pulse, blood pressure, and skin signs. Capillary refill is unreliable because of compromised circulation. Remember that some older people take beta blockers, which will inhibit their heart from becoming tachycardic. In your reassessment phase, repeat the primary assessment. A geriatric patient has a higher likelihood of decompensating after trauma. Interventions, broken bones are common and should be splinted. Do not force a patient with joint flexion or kyphosis into a normal position. Provide blankets and heat to prevent hypothermia. Communications and documentation. Communication can be challenging. Provide psychological support as well as medical treatment. Assessment of falls. Falls can be caused by medical conditions such as fainting, cardiac rhythm disturbance, or a medication interaction. Whenever you assess a geriatric patient who has fallen, it is important, it is extremely important To find out why the fall occurred, consider that the fall may have been caused by a medical condition or possibly life-threatening condition. Response to nursing skilled care facilities. Many calls will occur at nursing home or other skilled care facility. Calls can be challenging. Patients often have an altered level of consciousness. As I say, you're going to get patients from these facilities in probably the worst condition of their entire life. They're not going to be in good shape. Rarely, they're in good shape. Patients often have an altered level of consciousness. Staff may be spread thin and may not know how to assist. As I said before, they rarely have any valuable information to give you on the patient. Ask what is wrong with the patient that is new or different today. Infection control needs to be a high priority, right? So you have to ensure that you take proper precautions. These are not clean facilities. Methicillin-resistant Staphylococcus aureus infections are common, and it's simply an infection that is resistant to antibiotics. Many infections in the hospital are caused by vancomycin-resistant enterococci. The respiratory syncytial virus causes an infection of the upper and lower respiratory tracts. Clostridium difficile is a bacteria responsible for the most common cause of hospital-acquired infectious diarrhea. Typical alcohol-based hand sanitizers do not inactivate or kill C. difficile. Dying patients. More patients are choosing to die at home. That is their right. That is their right. And to be honest, if I should get any chronic illness that is life-threatening, I don't want to be admitted to any hospital. Let me die at home. That would be my request as well. I prefer to die at home. More patients are choosing to die at home rather than in a hospital. Dying patients receive palliative care, be understanding, sensitive, and compassionate. Determine if the family wishes for the patient to go to the hospital or stay in the home. Advanced directives, specific legal papers that direct relatives and caregivers about what kind of medical treatment may be given to patients who cannot speak for themselves. Dealing with advanced directive has become more common for EMS providers. May take the form of a do not resuscitate DNR order. Gives you permission not to attempt resuscitation for a patient in cardiac arrest. The DNR does not mean do not treat. Basic ABCs should still be provided. When transporting patients from nursing facility, consider these guidelines. Patients have the right to refuse treatment. A DNR order is valid only if it is in the form of a written order by a physician. Review state and local protocols. When in doubt, try to resuscitate the patient. Elderly abuse and neglect. Any action on the part of an older person's family member, caregiver, or other person that takes advantage of the older person's property, or emotional state. Includes acts of commission and acts of omission. The extent of elderly abuse is not known for several reasons. It has been largely hidden from society. Definitions of abuse and neglect among the geriatric population vary. Victims are often hesitant to report the problem. The abused person may feel traumatized by the situation or be afraid that the abuser will punish him or her for reporting the abuse. Elderly abuse occurs more often in women older than 75 years. Abusers of older people are sometimes products of child abuse themselves. Pay attention to the environment and conditions a patient lives in. Look for soft tissue injuries that cannot be explained clearly. Suspect abuse when answers are avoided or hidden. Suspect abuse when the answers that you're getting are just not logical. Information that may be important in assessing abuse includes caregiver apathy about the patient's condition, they just don't care. Overly defensive reaction by the caregiver. Caregiver does not allow the patient to answer questions. Repeated visits to the ED or clinic. History of being accident prone. Unbelievable or vague explanation of injuries. Psychosomatic complaints. Chronic pain without medical explanation. Self-destructive behavior, eating and sleeping disorders, depression or lack of energy, substance or sexual abuse history. Repeated abuse can lead to a high risk of death. Right, so pay attention to your table 35-5, categories of elder abuse: physical, psychological, financial. Signs of physical abuse. Inflicted bruises are usually found on the buttocks, lower back, genitals, inner thighs, face, and ears. Pressure bruises caused by the human hand may be identified by oval grab marks, pinch marks, or handprints. Human bites are typically inflicted on the upper extremities and can cause laceration and infection. Signs of physical abuse. Typical abuse from burns is caused by contact with a cigarette, matches, hot metal, forced immersion in hot liquids, chemical, electrical power source. Check for signs of neglect, such as lack of hygiene, poor dental hygiene, poor temperature regulation, lack of reasonable amenities in the home. Regard injuries to the genitals or rectum with no reported trauma as evidence of sexual abuse in any patient. Geriatric patients with altered mental status may never be able to report sexual abuse. Many women do not report cases of sexual abuse because of shame and the pressure to forget. And yeah. A lot of abuse occurs in these nursing homes, and it's quite unfortunate that that is the case. Right, and be suspicious if the nursing home tells you that you need to call before coming, right? Be very suspicious of that. If you have an elderly relative or family member in a nursing home, if you have to call before you turn up, be very suspicious. You should be able to turn up at any time, right? And as I said, these patients are just not in good conditions at all. And some of the persons that they have looking after them, they don't have any medical well, I can't even say they don't have any medical training, but the medical training is just not sufficient, right? I've had a personal experience with my father-in-law in a nursing home, right? He had atrial fibrillation, got a stroke, was recovering okay. Took him from Mobile Hospital, brought him into Kingston, put him in a nursing home. Within, I would say within a week, yeah, within less than 2 weeks, he died. And it's weird that when the practical nurse called about him, when she called, she said he's not responding. He's not breathing. So I said, how long has he been like that? 2 hours. She said 2 hours. So I said, did you do any CPR? You do any CPR on him? And her response was, what name so? Right? What is CPR? I didn't even go any further. I just told her, okay, do XYZ. We will be there shortly. And to this day, I've not mentioned to my wife what that young lady said to me, right? But I think my father-in-law is in a better place at this point in time. So you're gonna get patients in terrible conditions in these old age homes, and it's unfortunate that then I could not afford to keep him at home based on where we were living at the time. But I've learned from that experience. So if I have any relative, they're gonna be at home and they will be better taken care of. Anyway, this is the end of the geriatric chapter, geriatric emergencies.